morning once again. My apologies to the cataract team. We'll try to wind up as early as possible. My case titled From Relief to Rescue was a great learning experience for me. This is a case of a 38-year-old young female hailing from Uttar Pradesh who presented with loss of vision in both eyes along with severe pain, photophobia, watering since almost 5 months. Her symptoms had started in October last year, where a diagnosis of bilateral viral keratouveitis was made locally. The patient was treated with topical steroids and oral antivirals. Despite continuing her treatment, the symptoms worsened, for which a second consultation was done in February this year. The diagnosis of bilateral viral keratitis was maintained. Corneal scraping was performed to rule out secondary infection. The patient was then referred to us for further management. On presentation to us, this was the clinical picture. Both eyes showed near total epithelial defect with hypertrophic edges, diffuse corneal edema, severe thinning in the right eye as we can see here in the nasal quadrant. The left eye had an immune stromal ring with 2 millimeters of hypopyon. On further evaluation, there was no history of any ocular trauma or installation of any organic material in the eye. She had responded poorly to topical steroids and antivirals. A microbiological evaluation was again repeated at our center and was negative. So with this history and the clinical picture, I would like to ask our panelists what are their differentials on this case and how would they go about with this case.
So here you are dealing with a non-healing epithelial defect, right? So, history of viral keratitis in past, definitely HSV is high on our, diagnosis, and then we'll start the patient on lubricants along with antiviral orally to treat the epithelial defect, and maybe a tarsography would help, especially if the patient is coming from long distance and poor follow-up, then tarsography really helps in these patients.
Okay.
I think the whole idea is to stop the melting process. The stroma was undergoing necrolysis, right?
There was stromal edema with thinning in the right eye.
So this is in spite of antiviral treatment?
Correct. She was on oral antivirals and topical steroids.
And topical steroids.
Yeah.
Maybe, so it has not helped actually, the condition. So the deeper history, you ruled out any other usage, right? Any other medication?
So that is ahead, sir. That I'll be discussing.
Sometimes these patients are admitted for observation.
Correct.
Yeah.
So on probing a little further, we found out that she had procured pain-relieving medications from a local pharmacy, which she was using initially 3 times in a day, but then increased the frequency to installation to almost 1 hourly because of severe pain. So this helped us to arrive at a diagnosis of bilateral topical anesthetic-induced keratopathy. As we know, topical anesthetics are one of the most widely group of drugs in any ophthalmic practice, ranging from various diagnostic and therapeutic procedures to surgical procedures. Unsupervised and frequent installation can result in a wide spectrum of clinical presentation, ranging from superficial punctate keratitis to stromal thinning and perforation in advanced cases. The most common factors for abuse are lack of prescription monitoring and availability of over-the-counter eye drops. Though these cases are very rare in everyday practice, a differential should always be kept in mind because they resemble acanthamoeba keratitis and viral keratitis. There have been multiple case reports, most of them highlighting the fact that there's often a delay in diagnosis because the treatment is often, they are misdiagnosed in the early stages to be microbial keratitis. And also another point that was highlighted by the available literature was that there's always an underlying psychosomatic disorder in these patients. They have a very low tolerance for pain, and a psychiatric evaluation is recommended in all of these patients. So once the diagnosis was established, our aim was to promote the epithelial healing and control inflammation. Amniotic membrane graft was performed in both the eyes. In the right eye, and multi-layer AMG was performed along with tarsography. This is the clinical picture at 2 months. So once the surface healed and this inflammation was well controlled, we went ahead and did a penetrating keratoplasty in the right eye. This is the clinical picture at 2 weeks after the penetrating keratoplasty, where her vision has improved to 20/125. So just quickly to summarize, frequent installation of topical anesthetics can cause serious corneal damage. Any patient who is presenting with disproportionately intense pain, lack of response to medication, and a negative microbiological evaluation, a diagnosis of drug abuse keratopathy should always be kept in mind, and history is something that will help us to arrive at the diagnosis. The management is immediately we should stop the usage of drugs and methods to promote epithelial healing like AMG, tarsography, lubricants. a close follow-up and counseling is recommended because they have a very low pain tolerance and they can go back to using these eye drops again. Thank you.
I had one patient to share.
Yes.
She had SJS with severe dryness. She had underlying psychiatric issue. She had access to proparacaine. She went on using similar picture.
Okay.
And eventually she lost one eye and has a Boston K-Pro in the other eye now. So it's a very serious disease to be considered.
Okay.
Yeah. Thank you.
Thank you. Thank you, everybody.